So the cardiovascular section for the NAPLEX is so big that I decided to break it into two parts, just so it's a little easier to tackle for you. As this is broken down, we'll talk about atrial fibrillation, DVT-PE, CAD, all sorts of different cardiovascular terms that sometimes gets a little overwhelming to kind of differentiate between and why we need medications and where they're utilized and best practices. So hopefully I'll try to explain that a little bit better and differentiate each disease state and kind of why we use medications and where we use medications. So first we've got atrial fibrillation. Three really important points that I'm going to cover that I think are really highly testable points. Rate control. That's generally first-line therapy for managing the heart rate, the elevated heart rate in atrial fibrillation. Rhythm control, if rate control fails, is generally second line in managing that heart rate. And then third, anticoagulation, which is obviously a big role, a big part of what many pharmacists do, and you will most definitely be tested on anticoagulation at some point in your NAPLEX exam, I'm sure of it. So first off, what is atrial fibrillation? It's basically this rapid, irregular beating of the heart. As pharmacists, we don't diagnose, so I wouldn't focus too much of your attention on that. As far as symptoms go, this can be pretty variable and sometimes a little bit challenging to diagnose just by what patients are reporting. As pharmacists, we typically don't listen to a patient's heart where it's often diagnosed. So if you've got a patient experiencing dizziness, weakness, shortness of breath, feeling tired, those are really vague symptoms and often can happen, particularly in geriatric patients, and we might not know what's going on. Now, if you've got a patient reporting that they're having this fluttering sensation, this rapid heartbeat sensation, that's often indicative of something going on and potentially could be a good sign that it might be atrial fibrillation. There is different classifications of atrial fibrillation. Paroxysmal, that's less than 7 days in length, so this is an atrial fibrillation that basically goes away. Persistent, greater than 7 days, won't go back to normal on its own. And then permanent or continuous atrial fibrillation, which oftentimes those are the majority of our patients who are on chronic anticoagulation or chronic medication therapy for rate or rhythm control. So, first-line therapy, atrial fibrillation, controlling that rate will help control a patient's symptoms, or at least hopefully it will help control a patient's symptoms. Again, these are patients that are in that permanent chronic type atrial fibrillation state usually. And drugs of choice here, beta blockers, calcium channel blockers, and digoxin. I will break these down a little bit on the next slide there, but certainly beta blockers, you remember the mechanism of action there, or I'll talk about it at least maybe a little bit more in hypertension. Calcium channel blockers, kind of as the name implies, that way. Digoxin works by inhibiting sodium-potassium ATPase and impacts, contractility and heart rate and all that sort of stuff. So that can slow down the heart. Probably the biggest thing with digoxin, and the setting I see it used in most, is patients with really low blood pressure. Beta blockers and calcium channel blockers like diltiazem, verapamil, those can drop blood pressure further, which can obviously be a problem. And digoxin tends not to drop blood pressure like those other agents do. So a few more pearls. Beta blockers are typically used first, probably best tolerable, most comfort level, best studied. We're going to typically use selective agents, cardioselective agents, so metoprolol, atenolol, drugs like that compared to a non-selective agent like propranolol, which can maybe have a few more side effects and impact other things as well. So again, beta blockers usually first line. They will drop blood pressure. They will drop pulse, which is what we're trying to do. And then we've got calcium channel blockers if the beta blockers aren't deemed effective or intolerable. And the non-dihydropyridines are the only ones that can be used for atrial fibrillation. So diltiazem, verapamil, you got to remember those two have action on the heart compared to drugs like amlodipine or felodipine, calcium channel blockers, that don't have much action on the heart. With calcium channel blockers, swelling, edema is a really common thing. So if you see a case and you see a patient with heart failure, we do have to be a little bit cognizant of the fact that it might increase or worsen their edema, and we may look to use other agents. Versus systolic heart failure, if you've got a patient with that, beta blockers are preferred to be used due to their mortality benefit with those meds. Now, digoxin, plenty of clinical pearls on digoxin. I mentioned the sodium potassium ATPase, so digoxin actually competitively or competes with potassium, and it binds in that potassium binding site. So in patients with low potassium levels, digoxin may not have as much potassium to fight with. So in patients with hypokalemia, patients may be more susceptible to digoxin's effects. And some of those effects you might see: GI symptoms, CNS changes in the setting of toxicity, significant weight loss. That can definitely happen with digoxin. In my geriatric patient population, if I ever see weight loss and see somebody on digoxin, I'm making sure that we've had a digoxin level lately, for sure. Then obviously bradycardia, it's meant to bring the pulse down. All these can cause bradycardia. Digoxin is cleared by the kidney, so I've seen that happen quite a bit, where patient's kidney function gets worse and that digoxin can accumulate. There are a few drug interactions. Amiodarone is one that comes to mind, where that may increase dig concentrations, as well as any drugs that can worsen kidney function. And with worsening kidney function, those drug levels can go up. Target concentration, we're maybe a little more aggressive in atrial fibrillation versus heart failure, and maybe we target around that 1.0 mark versus CHF, maybe a little bit lower, 0.5 to 0.8 there. Now, if rate control fails, rhythm control may be utilized, and I wouldn't expect that the Naplex would test on kind of the ins and outs and differentiating when it's effective and when it's failed and that type of thing. I would really focus on rate control being first line. Has that been tried? Is that effective? If it isn't, rhythm control is second line. And then with rhythm control, recognize amiodarone's got a ton of clinical pearls associated with it. And I'm really not going to focus a lot on any of the other antiarrhythmics. They're just not used that often in clinical practice. So I would focus my efforts on amiodarone for sure. Definitely know that drug inside and out. You may be asked a classification question or something like that periodically, or mechanism of action. But by and large, I just don't see the sodium channel blockers or any other antiarrhythmics used that often. Most are comfortable with amiodarone. So those amiodarone pearls, extremely, extremely long half-life. Okay? And it's got quite a few drug interactions as well. So with that long half-life, those drug interaction effects might take a while to kind of present. So I mentioned digoxin can increase concentrations there. Warfarin levels, you may see it impact that. Now with something like warfarin levels, we're probably checking INR on a pretty regular basis. And, I would recommend checking an INR, maybe shortly after amiodarone is started, and then, depending upon the patient, maybe weekly thereafter, just to kind of get a sense of where that INR is going and if that amiodarone is impacting that. But again, amiodarone half-life is weeks, and so it can take a long time for that drug to really ramp up and get to steady state. And it also can take a while if you ever have a setting where you need to discontinue this drug. That drug or those concentrations are going to hang around for a while. So really important thing to remember there with the extremely long half-life. Liver toxicity, there's warnings on that, so we got to monitor LFTs periodically. Pulmonary fibrosis can happen. So if you've got a patient on amiodarone with breathing difficulties, we do have to recognize that amiodarone may be contributing to that. And I have seen cases of that, certainly. With that said, oftentimes patients on amiodarone are seen by cardiology. And I think that's an important point to remember and certainly involve them in the team and switching over to a different agent. To be brutally honest, I've never made a recommendation to switch amiodarone to, another antiarrhythmic. And, that kind of goes to my comfort level. But the overwhelming majority of these patients, and pretty much all of them, when amiodarone is being used, have a cardiologist involved because it's that complex of a drug and a complex situation, certainly with the heart, where we've maybe failed rate control and we've moved on to rhythm control and we're trying to figure out what to do. Thyroid impact, gotta monitor TSH. I remember a patient that had increasing signs and symptoms of depression, fatigue, things like that, and they were started on an SSRI. We did a bunch of different things, nothing seemed to help, and finally we checked a thyroid function, and they were on amiodarone, and they were hypothyroid. And there is literature out there that amiodarone does have the potential to cause both hypo and hyperthyroid. In my experience, I've only seen the situation where it's caused hypothyroid. Drug interaction, so I kind of talked about those peak effects there. Along with drug interactions, probably the most common thing I see flag up or get questions about is QTC prolongation. And bottom line, it's nice to have a baseline QTC. If their QTC is well within normal limits, 430, 440, 450, and everything is fine, the addition of another QTC prolonging agent is probably a lot less risky than somebody that's already presenting with the QTC at 500 or greater, for example. So again, having that baseline EKG to understand where that QTC interval is at is an important thing. So a couple of meds I think about, quinolone antibiotics, antipsychotics, macrolides, just a few examples there of QTC prolonging drugs that may exacerbate that QTC prolongation with the amiodarone on board there as well. Atrial fibrillation and anticoagulation. So this is the third big point I wanted to talk about. So when that heart kind of flutters and sputters and that type of thing, you can get an inadequate flow of blood. And with that inadequate flow or that potential for blood to stop moving and begin pooling comes the opportunity for clots to form. And in atrial fibrillation, we do some risk stratification to see if anticoagulation is worth it. And we found that patients with a higher CHADS-2 score are at higher risk for having a cardioembolic stroke, where basically a clot comes from the heart and gets stuck in the brain. So CHADS-2 VASC. So if you've got a patient with CHF, hypertension, elderly patient, diabetes, stroke, vascular disease history, these are all the factors. These are all the risk factors that we take into account. And oftentimes in the patients that I mostly work with, anyone with atrial fibrillation is going to have multiple risk factors, and it's pretty easy to tell that they should be on anticoagulation. Now, we do have to weigh the clinical adverse effect risk of anticoagulation. These drugs can cause bleeding. They absolutely do cause bleeding. And getting that patient past experience, recognizing, understanding if they've had bleeds in the past due to various agents and or just as one of their disease states, that's an important thing to note in patients with that past history. So it's always a risk-benefit type thing, but generally, score of 2 or greater, anticoagulation in a patient that hasn't been on it before is going to be indicated. Now, I will talk about the specific agents for anticoagulation coming up here in the next couple of presentations, but just wanted to give you that CHADS 2 scoring, very, very important risk assessment tool in atrial fibrillation. Valvular heart disease and atrial fibrillation. So if you've got a patient with mechanical heart valve replacement, warfarin is the drug of choice, and this is one of the unique settings where we have a higher target INR. So that's always kind of a good one to kind of remember in the event we're using warfarin and they have a mechanical heart valve. At this time, we're not seeing much evidence, and there probably isn't a lot of incentive for drug companies to study this, but we're not seeing these direct oral anticoagulants, the newer ones, the Pradaxas and the Eliquises and the Xareltos at this time in this setting. So let's talk about anticoagulation. Let's talk specifically about warfarin. Very, very important medication, highly testable medication, certainly. And kind of talk about indications, kinetics, of course, adverse effects, of course, and a few drug interactions definitely I wanted to mention too. As far as indications go, the overwhelming majority target INR is going to be 2 to 3. It's just something you have to know for sure. I mentioned the setting of that mechanical mitral valve, 2.5 to 3.5. We do have a higher goal. That's really the only setting where we've got a different goal. In rare situations, higher bleed risk, higher fall risk, I have seen target INRs, 1.5 to 2.5 in that ballpark. I have seen clinicians really try to target 2 to 2.5. So maybe they're at really high risk for stroke, blood clot, whatever, but maybe they're at really high risk for bleeding complications too, and they really, really want to try to keep tight control on that INR, which can be really, really challenging to do, but you may see some alternative goals there based upon clinical experience and past history. But by and large, target goal 2 to 3, mitral valve 2.5 to 3.5, or mechanical mitral valve. Now with warfarin, its metabolism is different depending upon which enantiomer we're talking about. So S-warfarin, that's the more potent warfarin, and 2C9 is the primary metabolite there. So you could imagine drugs that would impact or inhibit 2C9 would potentially have a greater impact on raising warfarin concentrations, maybe than a 1A2 or a 2C19 inhibitor, for example. Okay, and a couple of classic examples of 2C9 inhibitors: Bactrim, commonly used for UTIs, and Flagyl, commonly used for C. diff. Maybe not quite so much anymore with recent guidelines, but those are two kind of classic examples of drugs that maybe inhibit that 2C9 a little bit more than other agents, and you may see a really big increase in warfarin concentrations in that setting. Now with 1A2, 2C19, 3A4, I think of St. John's wort being an inducer and that lowering concentrations of warfarin, rifampin lowering concentrations of warfarin there, raising concentrations, you might have modest 3A4 inhibition with, some of the calcium channel blockers or drugs of that nature. And I think it's just important to recognize any new start of a medication. You definitely have to think about, okay, do I need to check an INR? Is that INR going to go way up and or way down, depending upon the whether we're using an inhibitor or an inducer? Oftentimes, I would say most commonly it's antibiotics that are going to interact, cause trouble. They can kind of work twofold, where one, they can work on these enzymes. The other thing they can do is destroy, kill some of those vitamin K producing bacteria. Remember, vitamin K is the antidote to warfarin. It will bring down warfarin concentrations, and some is actually produced in the gut. So if we kill those bacteria that produce it, we're potentially susceptible for a higher INR if we've reduced our vitamin K intake. Highly bound to albumin, so if you get drugs that displace warfarin from albumin, that's a higher free fraction, and that's a higher activity level of warfarin and maybe a higher risk of bleed there. Half-life, it does have a longer half-life. We only dose it once a day, maybe compared to some of the newer agents, which we dose twice a day, some of them. Adverse effects, bleeding, it's a no-brainer. Purple toe syndrome, this is a unique one. And, you might think, okay, somebody's got an acute DVT, why don't we just give them a lot of warfarin, similar to what we might do in ACS with clopidogrel or Plavix? Why don't we just give a lot of the medication to get that INR up quickly and get them anticoagulated quickly? Well, we don't do that because of a thing called purple toe syndrome. And it's very, very rare, and honestly, I think I've maybe seen it once, but it's one of those things that most people know about, and they understand that you can't start warfarin at a really high dose to get that INR up quickly. So often what we have to do is bridge if we're going to use warfarin, and it's acute, it's a short-term situation where we need to get anticoagulation on board. Probably most often historically, we've done Lovenox for a few days, bridging to warfarin until we get that INR up there. How long does it take to work? It takes a while. I mean, it definitely is variable from patient to patient. Depends upon the dose, depends upon absorption, interactions, lots of different things that can kind of impact warfarin and how long it takes to work, which is why we monitor INR closely. So, day 1, day 2, day 3, as we're starting warfarin, getting them to that goal, that target INR, it takes time, and all these clotting factors kind of indicate that it's hard to exactly predict how long it will take to begin working. 3 to 7 days is probably that ballpark time frame that we kind of target to get that INR to goal and maybe get them off of their bridging agent, whatever we're using there. But as far as mechanism of action, remember inhibition of 2, 7, 9, and 10. Those are the clotting factors, versus some of the newer agents just specifically target 10 or specifically target direct thrombin inhibitor, for example. With INRs, it can be a bit of a puzzle sometimes to figure out what's going on and why a patient has had an INR of 2.5 for 6 months and now they're at a 5 or a 4 or whatever. That can be tough to figure out. And the first go-to I always have is adherence. Is the patient taking them? Do I trust them to take it? What's their track record? And trying to figure out, did you miss a dose this last week? Did you miss 2 doses, 3 doses, and so on? Diet changes. So seasonally, I have seen this where maybe patients have a garden and maybe they're eating more, green leafy vegetables, getting more vitamin K in their diet. And I have seen seasonally that kind of change INRs. Remember, more vitamin K, lower INR. Drug interactions, kind of talked about those, antibiotics being a really common one. Again, we can have inducers and we can have inhibitors, so it can go up or it can go down depending upon which type of agent is started. Changes in disease state, something like liver change, usually that isn't, excuse me, usually that isn't very rapid. So oftentimes that's accounted for. And if you remember in hepatic dysfunction, we actually can check clotting factors, and oftentimes patients will have an elevated INR in very, very severe liver impairment because their liver is just not very good at creating those clotting factors anymore. Less clotting factors, more propensity to bleed, and a higher INR. CHF, so kind of changing fluid status, can impact absorption and the kinetics of warfarins. In a CHF exacerbation, you might see some fluctuation in INR there. Fever probably doesn't happen too terribly often in our geriatric patients, but in the setting of maybe a hypermetabolic state, you may see that drug chewed up a little bit quicker and maybe a lower INR. Vitamin K, so when is this indicated? Elevated INR and bleeding. That's certainly an indication. And you got to remember that vitamin K is not going to work right away. It does take a while, because that's often the argument for some of the newer anticoagulants that don't have a reversal agent is, well, what do we do, in the setting of too much anticoagulation and a bleeding situation? We don't have a reversal agent. Well, vitamin K isn't perfect either, because it does take some time for it to have its effects and reverse a an elevated INR type state and a thin blood type state. In an acute setting where we've got significant bleeding, significant blood loss, transfusion is what we're going to do in that setting. INR less than 9, no bleeding. Most, I would say, clinicians would probably be comfortable with educating that patient, saying be extremely careful. If you have any bleeding, come in right away. And they may not give vitamin K. Some may feel more comfortable giving vitamin K. Sometimes in giving vitamin K, rather than just holding the dose, you might get into this yo-yo type setting, where now you give all this vitamin K, and now they're way under anticoagulated. And then we got to go back up again and try to figure it all out. So, there's a little bit of an art to it, but certainly elevated INR and bleeding, absolutely. We're going to be given vitamin K because we want to get that bleed stopped as quickly as we can. Now on to the NOACs. So these are the novel oral anticoagulants, the new oral anticoagulants, sometimes called DOACs, direct oral anticoagulants, whatever you want to call them. I wanted to give a good background on these agents because they're definitely used in atrial fibrillation, DVT, and so on and so forth. So factor Xa inhibitors in general, definitely gaining in popularity. We don't have that lab monitoring. So that's really what patients like about it, or the primary thing patients like about it. Definitely less on the drug interactions. So that's certainly a positive. Again, that less frequent lab test is an awesome thing for patients. In the setting of, do we know whether you're therapeutic, whether you're adherent to the medication, that lab monitoring can be beneficial in a way, because if patients consistently got an INR of 2.5, we know they're taking the medication. Whereas with, factor Xa inhibitors, we got to trust that they're, taking it. We got to, maybe talk to a dispensing pharmacy or look at the dispensing records and see if they're getting it routinely filled, and try to figure it out from patient perspective and records, whether they're actually taking it. Because certainly if patient goes, day, 2 days, 3 days without taking it, or forgets to take things a lot, they're at risk for blood clots for sure. So when you might not choose them, so prosthetic valves, remember I talked about that mechanical valve situation. Adherence issues where maybe we want to keep tabs on that INR to see if we can trust that they're actually taking it. And warfarin, if a dose is missed, does have a little longer half-life, so that might be an advantage if a patient periodically misses doses. CKD, end-stage renal disease, that type of thing, warfarin's going to be your drug of choice there. That's a good question that I've definitely seen come up before. Cost insurance coverage is with any newer brand name medications is obviously an issue. And a lot of providers are pretty comfortable with using warfarin, and they sometimes don't like to rock the boat. So that might be why some prefer warfarin over factor Xa inhibitors. So first one, this is probably the one I'm seeing most frequently used. One downside with this is it is twice daily. So that is a potential downside if you've got a patient that has a really busy schedule. Maybe they're only good about taking meds once a day in the morning. That might be a potential downside to this one. Dose adjustments based upon age, creatinine, and weight. So you can see down below if they've got 2 out of 3, age greater than 60, body weight less than, so think really old, really light, or poor kidney function. And if they've got 2 of those 3, 80, 60, 1.5, it is a dose reduction that is recommended to 2.5 twice a day. Again, there's different, and that's for atrial fibrillation, 2.5 twice a day in the setting of 2 out of those 3. There is different dosing for DVT treatment versus prophylaxis, so definitely take a look at that. Make sure you're kind of aware of those dosing situations. There is also specific dose adjustments for 3A4 and P-glycoprotein inhibitors, so we don't totally get away from drug interactions with some of these medications for sure. But, clarithromycin, ketoconazole, itraconazole, ritonavir, those drugs aren't used real often, but we definitely need to be aware of that for sure. Now, Xarelto, once daily, so that's a potential advantage. 3A4, P-glycoprotein interactions possible there. Less than 30 mils per minute. We don't really have much guidance on use there, and avoidance is recommended. And, a lot of my geriatric patients, they've got a lot of stuff going on, and oftentimes they do have kidney function issues and kidney function problems. And so that is a challenge with this medication. And in that setting of their kidney function getting worse, it's like you probably got to switch them to something else. So we've got DVT dosing, DVT prophylaxis, atrial fibrillation. And here's one of my biggest frustrations with Xarelto is you may have to reduce the dose in elderly with creatinine clearance between 30 to 50 mils per minute, but they don't give you any guidance. They just say that the drug may accumulate more. So again, in an 85-year-old, you're probably going to have a creatinine clearance between 30 to 50, or it's very, very possible. And what do you do in that situation? So it makes it hard to have good guidance on using this medication that way. Edoxaban, I honestly can't say I see it used very much. I think a lot of people are scared by that boxed warning of, really, really good kidney function. So we do have some dose reductions. Again, similar P-glycoprotein 3A4 interactions, potentially similar to Rivaroxaban there. And some of the others avoid in extremes of weight as well with this one. So again, I wouldn't spend a lot of time worrying about this one. Now, Dabigatran is a little bit different mechanism. It's a direct thrombin inhibitor. This was one of the first ones to kind of come out. There is a GI bleed risk warning on this one, greater than 75-year-old patients. So again, you've got a 69-year-old with atrial fibrillation. Do you want to start Pradaxa and then, 6 years later have to change it to something else because you're worried about that risk? And then it's twice daily as well, which is a downside there. So I would say I've definitely seen some clinicians probably go away from this in favor of Apixaban. And I did just want to mention I have zero conflicts of interest on any of these medications, just reporting what I've seen utilized most in my clinical practice. DVT-PE. So we've got plenty of risk factors for DVT-PE. If patients obviously have genetic predisposition, hypercoagulable disorders, as far as modifiable risk factors, smoking, we can change that. Patients can quit smoking. Immobility, certainly patients can get moving, or we can keep them moving. And oftentimes we use mechanical pneumatic compression stockings, for example, to keep squeezing those calf muscles, keep that blood flow going. But that immobility can lead to a blood clot, certainly. And the medications, those are certainly modifiable. I've got a list of a few ones definitely you got to know that can contribute to DVT-PE. Probably one of the biggest ones I think of is birth control and estrogen-containing products there, which I've got a slide and a few listed coming up here. And estrogen, like I mentioned, Megase, I've rarely seen this in chemotherapy, sometimes in geriatrics too, to stimulate appetite. There is some risk with that medication, and it does increase the risk of DVT and blood clot type events, pulmonary embolism. And then SERMs, which again act on estrogen receptors, can contribute and potentially increase that risk of a DVT. Now, when selecting agents, we can certainly use quite a few different ones. So in the setting of acute treatment, you may see heparin-based product, low molecular weight heparin-based product utilized there. NOACs can be utilized there as well. Keep in mind with warfarin, we can use them for treatment and prophylaxis, but with warfarin, we have to bridge. And bridging is no fun. Nobody really likes to do it if we can at all avoid it. Life is simpler if we don't have to do it. So in the setting of bridging, you've got to start a Lovenox, and you've got to bridge to warfarin and take some time to get that INR elevated. So that's the challenge with warfarin there. And I think you're seeing a lot less of warfarin, particularly in DVT-PE. So breaking down the drugs a little bit. So low molecular weight heparin, again, these have immediate action. It's an injectable type medication. So some patients may struggle with that and the needle phobia associated with that. It is the drug of choice in pregnancy. So that's often a test question I have seen is, maybe somebody on warfarin or something like that. What do we do to prevent blood clots in that type of patients? Well, we can't use warfarin. So using injectable low molecular weight heparin is the way to go there. Dosing for treatment, 1 milligram per kilogram twice a day, 1.5 milligram or 1.5 milligram per kilogram daily. Obesity, you may see higher doses, obviously, if it's, dosed weight-based dosing and stuff. So you may see that. Some contraindications, so if a patient's had heparin-induced thrombocytopenia, that's obviously a problem and a reason we wouldn't use a heparin-based product. Kind of a cultural type thing that you might see periodically, or maybe have been asked a question about periodically. Heparin-based products are derived from pork products. So in patients, religions, Muslims come to example, Jewish comes to example as potential religions that may want to avoid anything pork containing. Just a little clinical quirk there. And avoid in dialysis as far as the heparin-based products go. And then warfarin and NOACs, certainly I think I covered those already a little bit. And, the pluses and minuses with each of those agents. Now, length of treatment for DVT. This gets a little bit dicey. Some things I think about is this the first episode? So if this is the first episode, if they've never had a DVT before, we're probably not going to do lifelong therapy, unless we've got a hypercoagulable disorder or something else factoring into this equation. But if it's just a first episode, we're probably not going to do any type of lifelong therapy. If it's a first episode and we've got a known cause and or there's a risk factor in play, that's a changeable risk factor. So for the example of you've got a patient taking birth control, like I mentioned before, and they've just started it maybe 3 months ago, 6 months ago, and now they developed a blood clot, never had any problems in the past, that's probably a well-documented, well-demonstrated cause that birth control contributed or caused the DVT. So in that setting, we're probably never going to go back on birth control or the estrogen-containing therapy, and we probably won't need lifelong DVT prevention either, because we've got a known cause with a first episode there. So if you've got a patient with multiple risk factors, that might lend towards a case of, maybe we do need to be more aggressive in using this for a longer period of time and continue to monitor that patient. All right, let's chat about acute coronary syndromes. So what is ACS? I would say acute coronary syndromes, remember 3 big things, and as far as the diagnosis goes. So STEMI is the most severe, non-STEMI is potentially a little less severe, and unstable angina is potentially a little less severe. Again, this can kind of waver a little bit. That's kind of how I categorize them. And certainly, there might be situations where unstable angina is worse than a non-STEMI, depending upon what else is going on with a patient. But by and large, if you hear of a patient that has a STEMI, that's kind of classically considered the big one in a heart attack in that situation. So STEMI stands for ST elevation myocardial infarction. And biomarkers are things like troponin and creatinine kinase. Those are elevated both in STEMI and non-STEMI. The only difference between STEMI and non-STEMI is non-STEMI has no ST elevation. So those are just kind of a few of the subtleties and differences there. Unstable angina, we don't have any biomarkers. It's basically a situation where we've got chest pain at rest. There's a new onset. It's not a predictable, a chronic stable angina type setting where the patient goes and exercises and they get the chest pain. That's a stable angina type setting. Unstable angina is where you get this new onset chest pain, but you don't have biomarkers and you don't have that ST elevation. Patient presentation, classic symptom you'll hear is elephant sitting on your chest, and that can happen to a lot of patients, but it might not either. So certainly there can be some vague symptoms, and women more particularly might present with atypical symptoms. Maybe they've got, arm tingling, maybe they've got back pain, maybe they're just fatigued, maybe they have some stomach upset, shortness of breath. Women tend to present a little bit differently than men with the classic pressure in the chest sensation. Now causes. What causes this? So an MI is basically a blockage of flow that causes damage to the heart. A level of ischemia that can cause damage, that can cause injury to the heart. And that blockage of flow can be due to a few different things. Classically, we think of coronary artery disease and the plaque buildup. really narrowing those arteries and increasing that risk for ischemia or lack of blood flow, causing that eventual damage. So that's probably the most common situation. There are other blockages that might happen that might lead to a heart attack type setting. I'm not going to talk about them a whole lot, but if you think of a vessel spasming and not allowing blood flow through because it spasms so tightly, that's a situation where you could get some heart damage due to that lack of blood flow. Same thing with a coronary artery embolism. You might get a blockage in flow that way, but again, overwhelming majority of cases, kind of that chronic, long-term fatty deposit plaque buildup leading to ischemia. Immediate care in the setting of chest pain, STEMI, that type of situation, myocardial infarction. Just remember the acronym MONA. That'll give you a good sense of the direction there. Aspirin, morphine, oxygen, nitroglycerin. Important to remember that acronym in the immediate care setting of a acute coronary syndrome situation. Now PCI is basically that stenting that you hear so much about. Do you have a stent? Do you not have a stent? That type of thing. With PCI, it is the procedure of choice, and we do different things based upon whether PCI is possible or not possible. Fibrinolytic therapy is an option if a PCI is not possible. So in the United States here, we're pretty fortunate where we can probably get a patient to a setting that can do a PCI and provide stenting and things like that in a relatively decent time frame. Now, in maybe other countries, remote locations, that may not be possible. So fibrinolytic therapy to basically bust up that clot may be indicated in that situation where we can't get them to a center that does stenting and PCI. Heparin-based products are given in conjunction in a PCI type situation. So remember MONA, but then also remember that heparin is often given as well. So keep in mind, you got to assess bleed risk, that type of thing that's going on there. In the setting of maybe a heparin-induced thrombocytopenia or something like that, bivalirudin or Angiomax is a potential alternative. And that mechanism, it is a thrombin inhibitor. So again, these agents are meant to thin the blood and can thin them a little bit too much sometimes too. There is that kind of risk too. But certainly in a setting of acute myocardial infarction, that's a pretty big deal. And we need to treat that very, very seriously first and foremost, in addition to kind of worrying about the bleed risk. Some examples of fibrinolytics, again, these are considered if PCI is not an option, but in most settings, I would say PCI is going to reign supreme. Contraindications to some of these agents, you got to think about bleeding issues. So if patients had an active intracranial hemorrhage or recent intracranial hemorrhage, active GI bleeding, if it's significant and severe. Also, if you think about, pressure on the vessels and higher blood pressure, you may end up in a situation where a bleed is much more likely, and it puts a patient at much higher risk when we use a blood thinning agent and they already have high, uncontrolled, unresponsive hypertension. NSTEMI and unstable angina. So STEMI, no-brainer. We go do PCI. It's that's the intervention of choice. Get that stent in, and I'll talk about the agents we use kind of post-op or after that stent, long-term. NSTEMI, unstable angina, it's a little more murky as far as what we do here. And a lot like the CHADS-2 to atrial fibrillation, we do have a risk score where we look at a TIMI score, thrombosis and myocardial infarction, and this will help guide us. Do we do early invasive strategy like doing a PCI and stenting? So higher risk patients, again, elderly, risk factors certainly for CAD, smoking, hypertension, cholesterol, diabetes, other tobacco use potentially maybe, recent aspirin use, so this may indicate that they're at higher risk and they've had something happen even despite aspirin use. Severity of chest pain, that's a little bit subjective certainly there. If they've had a non-STEMI, they've got those elevated cardiac biomarkers, so that can certainly lead us down the path of doing stenting. And then ST change, that based upon that too, that may lead towards a higher risk patient. So lots of things in that TIMI risk scoring, and obviously the more factors that come into play, the more likely we're going to do early invasive strategies there. Now, as far as hospital discharge, so let's say we've got a patient with a stent, had a heart attack. We're going to do dual antiplatelet therapy. Aspirin and probably most often what I see is clopidogrel. It's generic, it's cheaper than some of the other agents. And these work by P2Y12 inhibitors, or adenosine diphosphate receptor antagonists is another terminology there. With clopidogrel, Plavix in particular, it's definitely important to think about the 2C19 interaction. It's still up for debate as to how much of an impact that plays, but the classic example is omeprazole and some of the PPIs inhibiting 2C19 and potentially leading to lower concentrations of the active metabolite of clopidogrel, which may put a patient more at risk for another event or a clotting event. So that's a challenge. It's a challenge to know what to do there. Pantoprazole may be a little bit less 2C19 inhibiting, so I definitely have seen some clinicians use that PPI where indicated. Now, if we can step down to an H2 blocker, or better yet, they don't need a PPI long-term altogether, it's nice to try to avoid that for sure. But just wanted to make sure you're aware of that genetic drug potential interaction. You can also have a slow metabolizer or a rapid metabolizer. So rapid metabolizer at 2C19, they're going to end up with higher concentrations of that active metabolite. A slow metabolizer, they're going to end up with lower concentrations. So again, definitely need to think about that and what to do there. There is certainly bleeding risk whenever we thin the blood with aspirin and a P2Y12 inhibitor. Bleed risk is always going to be at the forefront of weighing that risk versus benefit. ACE or ARB, beta blocker, statin, all drugs of choice on post-MI discharge. ACE and ARB, obviously we have to think about hyperkalemia and all the adverse effects that go along with that. Beta blockers, same thing. We'll talk about those in the hypertension section, and certainly talk more about statins too in the hyperlipidemia section. All right, let's talk a little bit about, this is more of a, primary care, chronic disease management, looking at coronary heart disease as well as cardiovascular risk. So first off, we've got atherosclerosis, and this is really that plaque formation that may lead to an MI, a heart attack type event. And over time, as we get older, as we, maybe have a poor diet, high-fat diet, those type of things, we may be at more risk for developing some of those things. Obviously, smoking, diabetes, lots of other risk factors too there. And that narrowing, that plaque formation within the walls, the vessels, can certainly lead to blockages, like I had kind of mentioned when talking about acute coronary syndromes. As far as risk stratification goes, I think it's pretty common sense as to what goes into play here. So blood pressure, diabetes, cholesterol, weight, smoking, family history, those are really the biggies as far as the cardiovascular risk and what plays a role and what we can do to try to help prevent events from happening by managing some of these other consequences or some of these other situations. I would, and I've got a link coming up here, I would check out the risk calculator for primary prevention. I think it's nice to plug and play with some numbers, gender, race, cholesterol levels, blood pressure, diabetes, smoking. One of the eye-openers for me is always smoking. And when you click yes or no, as far as smoker or non-smoker, that is a huge, huge risk factor, and it greatly increases the 10-year risk of an event happening. So definitely I would encourage you to go check out a couple of these calculators, plug and play with the numbers. It also kind of help you memorize some of those risk factors. And so this is what it kind of looks like a little bit. Maybe got a little small on your screen. I apologize for that. But with that, you can see. So we've got 55-year-old male, not African American, cholesterol. We've got 132. So really not bad cholesterol by any stretch of the imagination. Blood pressure, that's kind of a unique diastolic blood pressure, but I think you kind of get the point. And you can see this is a fairly younger person, so diabetes and smoking, if you were to pull those out of there, that would greatly, greatly reduce their 10-year risk of heart disease or stroke. And so again, like I said, just go there, check it out, play with the numbers a little bit. Like I said, that diastolic was a little bit goofy there. But I think you get the sense of some of the risk factors that come into play here and how they can substantially increase your 10-year risk. So ultimately, what are we trying to do in assessing cardiovascular risk? We're trying to reduce that risk of heart attack and stroke. That's ultimately what we're trying to do. That's the message I relay to patients when I'm working with them. There's a reason why you're on a statin. I know you don't like it, but here, it cuts your 10-year risk, by 3%, by 5%, whatever the case may be, depending upon the aggressiveness of statin therapy there. Platelet inhibitors, so, if we've had MI in the past, we're maybe on dual antiplatelet therapy. If we're doing primary prevention, we're probably just going to be on baby aspirin in that setting. Getting patients to lose weight, stop smoking. Angina, if that's a problem, you may see meds utilized there, like calcium channel blockers, beta blockers, long-acting nitrates you might see as well. And then, of course, antihypertensives to get that blood pressure down and change that modifiable risk factor. Antiplatelet meds, I think we kind of talked about those quite a bit as far as the mechanism, how they work, that type of thing. Aspirin often combined with clopidogrel in the setting of somebody after a heart attack. In primary prevention, we typically don't use dual antiplatelet therapy. So statin consideration, so high rates of patients quitting these medications. I think it's like after a year or two, I think it's like a 50% adherence rate that patients are actually still taking these. So important to kind of look at past history. Using those CV risk calculators can give you a sense of whether we should be doing moderate intensity, high intensity, and what type of aggressive statin therapy we should be doing. I'll talk about these more specifically in the hyperlipidemia section. Now, anti-angina medications, so we've got nitrates, and you will see long-acting nitrates used to kind of help with that chest pain. And one thing that sometimes comes up is that idea of tolerance and nitrate tolerance, and trying not to use these for a 24-hour period. How that plays out clinically and in real life practice, sometimes that's a bit of a challenge. I've definitely had patients taking a lot of nitrates and they still seem to work okay that way, even though they're pretty much getting nitrates around the clock. So we try to get a nitrate free period, and oftentimes that's maybe at night or overnight. But I have seen them given around the clock as well there. So short acting, so this is an acute chest pain, angina type situation. Understanding that patients know how to use it, can use up to 3 doses every 5 minutes, for a total of 3 doses, I should say. And then obviously if chest pain is not improving, if it's a unique situation where it definitely feels different, we've got to encourage emergency type care. And then beta blockers, calcium channel blockers, I mentioned those before, and I'll talk about those more specifically within the hypertension section. Antihypertensive therapy in the setting of coronary heart disease, cardiovascular risk. ACEs and beta blockers definitely have really good evidence as far as mortality benefit in the setting of post-MI for sure. Calcium channel blocker, definitely see that more so used probably in the setting of preventing angina and chest pain type symptoms there. But again, our goal is definitely to try to get that blood pressure down and make sure we're changing that risk factor to help improve their risk or lower their risk of an event happening. Now let's talk about blood pressure. I've kind of alluded to some of the medications in some of the other sections, but we're going to get into the agents and a little bit more and how they work and when they're used and some of the potential adverse effects that you're going to see in clinical practice and likely that you're going to see on the NAPLEX. So plenty of complications from elevated blood pressure. And I think these are certainly good to remember, just to educate patients, just to obviously help you recognize why we're managing blood pressure. And obviously for your exam, these might come up as well. Now goals, as far as JNC goes, the latest we've had is JNC 8 and less than 150 over 90. Exception is 140 over 90. In CKD or diabetes or patients younger than age 60 as well, we might have a little bit more aggressive goal if they've got other things going on. So again, overwhelming majority of patients is probably less than 150 over 90 for our elderly population for sure. And exception being if they do have higher risk situations. Now, we have had some updates. JNC was a few years back now, and now we've got ACC Hypertension Updates, and now we're getting back towards a more aggressive goal. So what's considered an elevated systolic is 120 to 129. Now, they don't say to start pharmacotherapy here. They recommend lifestyle interventions, exercise, DASH diet, and so on and so forth. But JNC 8 cutoffs were obviously much higher. Again, depending upon those risk disease states and age. So again, elderly patient that doesn't really have any at-risk disease states, goal of 150 over 90. Everybody else, 140 over 90. So again, that lower threshold for beginning pharmacotherapy is important to note here. So Will they give you a question where maybe they've got somebody with a blood pressure of 135 over 75, and should you leave them alone? Should you increase the dose? Should you add a medication? I just, with these guidelines kind of being a little gray and that type of thing, I can't perceive a situation where you'd be asked a question on that. I would think you'd be more likely to be asked a question, where you're given a systolic blood pressure of, 155 or 152, and what do we do as far as which medication would you add and why would you add it, and compelling indications and all that sort of stuff. That would be, in my mind, a much more likely situation, just given the differences between these two latest kind of guidelines and hypertension updates. So again, this is from the newer updates. So stage 1 hypertension, lifestyle modification for low-risk patients, medication therapy for high-risk patients. So those with diabetes, CKD, they've had a cardiovascular event, maybe a stroke or a heart attack in the past. Pharmacotherapy, yes. By AHC, ACC, the newer updated guidelines, yes. These should be treated to a more aggressive goal, probably in the 120s or less. And again, they've kind of factored in that risk stratification. And they say if patients are greater than 10% ASCVD 10-year risk, then we should be more aggressive with their blood pressure lowering therapy. Clinical factors that you must think about: age, life expectancy. If you got somebody on hospice, do we care if their blood pressure is 142? Are we going to get more aggressive with their antihypertensive therapy? No, we're likely not going to. Same thing with patients that have had a lot of falls, a lot of low blood pressure history in the past. We're looking at quality of life, not quantity potentially there. Other drugs, so definitely looking at medication-induced hypertension. That's something I do on a pretty regular basis, making sure that drugs aren't making things worse, and I've got a list coming up here we'll talk about. And then medical causes, not something we generally think about as pharmacists, but I'll throw out a couple here. So drug-induced, definitely know these as adverse effects. If you are presented a case, patient with high blood pressure, and you see they're on really high doses of NSAIDs, stimulants, maybe they've had recent aggressive corticosteroid therapy for their rheumatoid arthritis flare, and we see a spike in blood pressure, recognize that those medicines could contribute to that. SNRIs, I would say, is probably a little less common. Maybe I've seen a little bit more so with venlafaxine at higher doses, but it is something to think about, particularly if the timing makes sense, where we've started one of these medications and now their blood pressure is up, 5, 10, 15 points. Okay, is it due to that medication? And then ESAs, so those are erythropoietin stimulating agents like Epogen and things like that. They can definitely raise blood pressure. A few medical causes, so sleep apnea is one, where you may see a patient that gets put on blood pressure med after blood pressure med, and they keep jacking up doses, and it doesn't seem to be coming down. Definitely need to think about medical causes. So sleep apnea, thyroid issues, maybe we're hyperthyroid, raising that blood pressure. Maybe we've got a low TSH. Adrenal gland problems, any type of kind of rare, unique cancer type situation where maybe the adrenal gland is dysfunctioning or throwing out inappropriate amounts of different hormones or something like that that are raising blood pressure. That's kind of a rare situation. Also maybe in withdrawal or illicit drug use, so maybe stimulants like cocaine, things like that can raise blood pressure. And then, opioid withdrawal, benzo withdrawal, you may see some anxiety, some tachycardia, and may see some elevated blood pressure associated with that as well. Now the medications. So ACE inhibitors. You got to remember the ending, PRIL for the generic names. I would definitely memorize most of these brand names. I've definitely seen all or most of them, and most commonly, lisinopril probably a go-to drug, enalapril, and benazepril are probably the three most common that I see, at least in my practice. Side effects, cough. If you ever get presented a case and a patient's got a cough, and it's a dry, hacking cough, and they don't have an acute infection going on, you got to look through that med list and see if you notice an ACE inhibitor. Kidney impairment. So we want to check kidney function following starting and increasing doses of ACE inhibitors. Typically, it's usually a 30% change that we worry about. So if you've got a creatinine at 1.1 and a patient goes up to 1.2 on next lab check, 2 weeks, 4 weeks after starting an ACE inhibitor, it's probably not something you're going to worry about. If they go up from 1.1 to 1.4, 1.5, yeah, you're probably getting a little more worried about. Diuretics and NSAIDs in combination with ACE inhibitors really can increase that risk. And in the setting of something like heart failure, you're oftentimes using diuretics with ACE inhibitors. So really, really critical to keep an eye on that kidney function. Low blood pressure, and then hyperkalemia. So it's important to think about potassium. Do we have a baseline potassium level? Since we started an ACE or an ARB, where is that potassium level? Are we adding other agents that could increase potassium, like a spironolactone? Drug interaction with trimethoprim is one I've seen cause elevated potassium levels. And then, are they on a potassium supplement, which many patients who are on diuretics are on a potassium supplement. And as long as it's monitored, as long as it's checked, and we're within normal range, that 4 type range, we're fine there. But it needs to be monitored for sure, and ACE inhibitors need to be discontinued and or reduced in the setting of hyperkalemia or elevated potassium. Clinical pearls. ACE inhibitors can exacerbate CKD, but it's kind of a catch-22. They can also be renal protective, so they're often drug of choice in patients with diabetes and hypertension. Angioedema is kind of a rare side effect, but it is if I ever hear a patient have lip swelling, difficulty breathing, ACE inhibitors are the first drug I think of. Has that started? Has that changed? Is it being held? Is it being stopped? Unique characteristic of ACE inhibitors and the renin-angiotensin-aldosterone system altogether is that African Americans may not respond as well compared to other ethnicities. So ACE inhibitors, again, kind of work on that RAS system, renin-angiotensin-aldosterone, ultimately prevent the formation of angiotensin II, which is a potent vasoconstrictor. ARBs block the binding angiotensin receptor blockers. They block where angiotensin II binds. So we really don't want to use these together. They work on the same pathway. We're putting our patients at risk of significant hyperkalemia, angioedema, kidney impairment by using these together. It doesn't make any sense mechanistically. So if you ever see a question where a patient's on both, definitely one should be gotten rid of. ACE inhibitor, compelling indications, so diabetes, stroke. Remember I mentioned coronary artery disease, so in patients with a heart attack, ACE inhibitors are definitely recommended there to help improve mortality. CKD, again, these can help preserve kidney function by reducing blood pressure and shown benefit that way, but they can also exacerbate it too. So that's why we need to check kidney function following initiating or increasing doses. And CHF, definitely these in combination with beta blockers in CHF have been shown to be beneficial. ARBs, I'm not going to spend a ton of time on these. Remember the last part of the word sartan for all the generic names. That's pretty easy to remember, I think. Most common, Diovan, Cozar, Benicar, maybe Avapro I've seen periodically. Micardis, Anacan, rarely. And honestly, Edarbi and Tevitin I haven't seen used at all. ACEs and ARBs, extremely, extremely similar. They work the same way, work on the same pathway. They just work at the binding site, the ARBs do, where they prevent binding of angiotensin to its site, which causes vasoconstriction. And so that ultimately leads to lower blood pressure. So think ACE inhibitor minus the cough. ARBs tend to not cause that cough as much. And the theory is it's through bradykinin release and where the ACE inhibitors work on the pathway and different things like that. But again, clinically, looking at patients, if a patient has failed an ACE inhibitor due to cough, we absolutely can try an ARB. So don't forget that. And in the setting of patient having compelling indications like diabetes or CHF, we definitely will want to try an ARB and see if they can tolerate that. Thiazide diuretics, chlorothiazide, chlorthalidone, probably chlorthalidone, hydrochlorothiazide are the drugs I see most often used for hypertension. Indapamide or metolazone, probably metolazone much more commonly, or brand name Xarelto. That's what I see used to augment fluid loss in CHF. So in patients that aren't responding to a loop diuretic by itself, I definitely see metolazone added, 1 day a week, 3 days a week, sometimes every day, if it is that significant. Adverse effects, you got to remember anytime we increase fluid to the bladder, it's going to make you go to the bathroom more. So these drugs run off fluid, pull fluid out of the body, into the urine, increase urine output. So dose these in the morning so patients aren't getting up to go to the bathroom all night. Electrolyte depletion, so potassium, sodium. Potassium probably the more prominent one there as far as depleting that. Low blood pressure. With the loss of fluid, we always have to think about the possibility for dehydration and inadequate perfusion to the kidney, and that can present as a rising creatinine level. And in that setting, we're probably going to have to back off of the diuretic. And I'll talk more about this balance in CHF, but it can often be really, really challenging as far as if you're using these drugs for fluid loss and managing how much perfusion we get to the kidney and are we hurting the kidney versus how much fluid is accumulating and how much do we need to get rid of. So that can be a challenge. But in the setting of blood pressure, we're typically just using it for the blood pressure lowering effects, obviously, and not necessarily for the fluid status, but we often do see it used for both as well. So rarely, I have seen thiazides contribute to hyperuricemia. So that's elevated uric acid, which is really, really important in gout. You got to remember that one. Also, rarely, I have seen it contribute to an elevated calcium in the blood. Mechanistically, the way these work, they help the body retain calcium. Okay? So a couple of elevated levels that you might not think about with thiazide diuretics, but they certainly can happen. So again, use caution in gout, mention that. So poor kidney function with like hydrochlorothiazide, chlorthalidone, these might not work as well as far as antihypertensive effect goes on this. There's a little controversy surrounding that, but in the setting of the kidneys not working that well, these drugs may not be quite as effective. Timing your night, avoid that. if we can, certainly. Hyperglycemia, there is mild to moderate potential that blood sugars could be elevated a little bit from thiazides. However, I can't really remember a situation that it was clinically significant or clinically relevant. So I wouldn't worry about that one too much, but there is a rare potential. With the poor kidney function, I did want to add that metolazone may tend to work a little bit better as far as removal of fluid. Again, not necessarily for hypertension, but it may work a little bit better as far as fluid loss in patients with poor kidney function. Calcium channel blockers, so its mechanism, obviously they work on calcium channels. I think that's pretty easy to remember, as long as you remember the classification of these. Amlodipine is probably the most common go-to drug I see. Nifedipine I do see occasionally, and I've seen that in the setting of pregnancy sometimes, where we've got some evidence there for that one. Non-dihydropyridines, I talked about those a little bit in atrial fibrillation. Remember that these act on the heart and can kind of reduce that heart rate in this setting of atrial fibrillation. Edema, so patients in CHF, we've got to be a little bit diligent there to keep an eye out for those patients. Constipation is a potential concern there. And simvastatin, there is an interaction. I always throw that one out there because simvastatin is used so commonly. And what will happen with the calcium channel blockers, amlodipine, so there is a dose limitation on there. Don't use simvastatin over 20 milligrams. And as well as the non-dihydropyridines. So simvastatin concentrations can be significantly increased with the use of those meds. Compelling indications, angina, so atrial fibrillation is another one. I talked about those. Cardiovascular disease risk can help with that. And that caution in heart failure I mentioned. Beta blockers. So what I would remember here for sure is propranolol and nadolol are non-selective agents. I would say propranolol is the one I see used most common. I think most have a comfort level there. As far as cardioselective agents, metoprolol and atenolol are definitely used the most common that I see. Carvedilol is indicated in heart failure, so you may see that used there. That has some alpha blocking activity. Labetalol also has some alpha blocking activity. So those are probably the big ones that I see used most often, and just a few important points about selectivity that I wanted to mention. So again, there's kind of the list for you. I think important agents to kind of remember in their selectivity. Compelling indications. So there's a lot of compelling indications for beta blockers. So CHF patients, yes, we do get aggressive with beta blockers. We try with systolic or reduced ejection fraction heart failure. We definitely do use beta blockers. We try to push the dose. A lot of times in our elderly geriatric patients, they can't tolerate it or the blood pressure gets too low. So sometimes we're kind of limited in not being able to push the dose there. In post-MI, definitely indications there. Angina, atrial fibrillation. Remember, the atrial fibrillation lowers that heart rate there. Migraines, you will see these used. I would say most often I see non-selectives used, probably propranolol or Inderal used most often there. Portal hypertension, which can lead to esophageal varices in cirrhosis and liver dysfunction. That's a setting that I see non-selectives used, particularly, again, propranolol, Inderal. Thyroid storm's another one where you might see beta blockers used to kind of help bring down that heart rate, the tachycardia, the blood pressure elevations that can happen. Tremor, again, non-selectives, I would say more used there, propranolol. Rarely I have seen them used for anxiety. Not real common, but might be something you see periodically. So with beta blockers, I remember breathing, I remember heart rate, I remember hypoglycemia, and significant risk of rebound hypertension in patients on higher doses who maybe miss a couple doses. So, few important things to remember. So, how significant is that asthma airway disease thing? I will definitely see patients on both beta blockers and beta agonists. It definitely happens. So, if you've got a patient where a beta blocker is indicated in, let's say, reduced ejection fraction CHF, and you've also got a patient with COPD, are we not going to use a beta blocker because of their breathing? Okay. And the answer is likely we are going to still use that beta blocker. Now, with that said, if you see a beta blocker added, and maybe more particular, a non-selective beta blocker added, like propranolol, and you notice that a patient has shortness of breath, difficulty breathing after that's added or increased, well, yeah, then definitely let's look at that agent and, can we use something different for propranolol in migraines, for example? Can we use something else? And so on and so forth. So definitely something to keep an eye out, but using metoprolol in the setting of asthma, can you do it? Yes, absolutely. But you do need to kind of monitor and keep an eye on breathing and educate our patients about that. Pulse, these drop the pulse, so we're going to monitor that. Obviously, we're going to monitor blood pressure, make sure it's not falling too much. And along with blood pressure, along with breathing, is also blood sugar. And rarely you might see some hypoglycemia masking. This is always kind of a classic test question. I can't say I see it happen too often in clinical practice. I would say it's probably more likely with a non-selective agent to see the masking of some of those symptoms. And kind of classically, the symptom that isn't related to the beta blockers that you still should see is sweating. That's a symptom you still should see with a hypoglycemia episode, where maybe some of the other symptoms of hypoglycemia aren't present. Alpha blockers, important to remember these. So these are specifically for hypertension. You'll notice I don't have tamsulosin in here, which is Flomax, because that is more selective for the prostate. We don't use it in management of hypertension, but you may see these used for dual purposes, BPH and hypertension. Definitely not first-line agents for sure, and that's because they can cause significant drug-induced orthostasis. So, and to avoid this, especially with the first few doses, that really significant drop in blood pressure, we'll dose them at night to try to prevent that, or patients go to sleep rather than they're up and around and moving and getting dizzy and at risk for falls. Again, BPH, compelling indication. These can kind of help open up and relax that passageway for urine to flow through in BPH. Rarely I will see prazosin used off-label for nightmares as well. It's kind of a unique psych condition you might see prazosin help for. Hydralazine. This is a tough med to get excited about using simply for the fact that it's dosed 3-4 times a day often. And in patients taking it for blood pressure where, you can't really feel a benefit generally with lower blood pressure, it's hard to keep them adherent on a 3 or 4 time a day drug. It really is. Kind of a unique clinical pearl with hydralazine. You got to remember lupus. It can cause or exacerbate a lupus type syndrome, which I do kind of have a section explaining some of those symptoms. Interestingly, hydralazine is contraindicated in coronary artery disease, which may be a significant chunk of your patients there. And again, direct kind of vasodilator by mechanism, so that risk of hypotension, low blood pressure, dizziness, orthostasis may be a little bit higher there. Clonidine, this is kind of a wacky, unique drug. It's a centrally acting alpha 2 agonist, I believe. Side effects. There's just troublesome side effects with clonidine. Dropping blood pressure obviously is one, but in the elderly, it's particularly not well tolerated. Can cause sedation, dizziness, dry mouth. Can also impact pulse a little bit sometimes and cause a bradycardia type situation. Because it's such an old drug, it's kind of like propranolol of the beta blockers. It's kind of got some unique uses. You may see it used in withdrawal of various agents. I know I've used it in opioid withdrawal, or I've recommended using it in opioid withdrawal. ADHD, you may see it utilized for that in patients that maybe don't want a controlled substance, that type of thing. Because of its nice dry mouth adverse effect, you may see it in clozapine excessive salivation in that setting as well. So again, lots of unique uses here. One formulation consideration with clonidine is that it does have a patch formulation. So that is definitely something I have recommended in the setting of a patient that can't do oral meds, or maybe just that rare intolerance, highly intolerant patient to every single medication that they take orally. Clonidine patch might be a consideration. In addition, I did want to add that that clonidine specifically, there is a significant possibility for rebound hypertension, a lot like the beta blockers. So if you've got a patient on a pretty moderate or high dose of clonidine, keep that in mind, that if they come off of that, you definitely don't want a cold turkey. You'll probably run into a situation where we get significant rebound hypertension.